Hello and welcome back to Dr. Reyam Academy. I am Dr. Reyam. Today's video is about management of preterm premature rupture of membrane. Once preterm premature rupture of membrane is identified, the general scheme shown in this table can guide the management. Here we see four groups divided according to the gestational age. The first group, those with gestational age less than 24 weeks. The second group, those with gestational age between 24 to 31 weeks. The third group are those with gestational age from 32 to 33 weeks. And finally, the last group are those from 34 weeks or more. It is useful to look at the 6 items of management of preterm premature rupture of membrane. These items are the time of delivery, whether it is expected or induced. The second one, the administration of Group B Streptococcus prophylaxis. The third item is the corticosteroid administration. And the fourth one, antimicrobial administration. Then tocolytics administration, and lastly, the indication of magnesium sulfate. Let it explain it in details. When it comes to the decision on whether to deliver, to induce, or to adopt expectant management, it's actually based on the gestational age. So, in the woman with gestational age of 34 weeks or more, those women should have induced labor. But the patients with preterm premature rupture of membrane from 24 weeks to 33 weeks, this group in the middle, they should be cared for expectant management until 34 weeks. And the woman with premature rupture of membrane before the viability should be counseled about the impact of immediate delivery and the risk and the benefit of expectant management. Regarding the administration of Group B Streptococcus prophylaxis, all women with premature rupture of membrane from this age group to the end should receive intrapartum chemoprophylaxis to prevent Group B Streptococcus, with exception those with gestational age less than 24 weeks. This first group, it is contraindicated, no need to give it. Single dose of corticosteroids should be given to the woman with preterm premature rupture of membrane at 24 weeks to 31 weeks to 33 weeks, sorry. But gestational age more than 34 weeks or less than 24 weeks, the corticosteroid may be considered. Now, the antibiotic is recommended for women with preterm premature rupture of membrane to reduce the risk of infection and to prolong the latency, but not recommended for women with preterm premature rupture of membrane more than 34 weeks gestation. Regarding tocolytics, there is no consensus on its use, and magnesium sulfate is given for neuroprotection and may be considered in patients with premature rupture of membrane of less than 31 weeks group. Most clinicians hospitalize women with rupture of membrane. Concerns regarding the cause of lengthy hospitalization are usually debatable because most women enter labor within a week after membrane rupture. In a study assigned 67 women with ruptured membrane to home or hospital management, they found that the maternal hospital stays were reduced by 50% in those sent home. They also found that no benefits were found in those hospitalized. Regarding intention delivery, before 70s, labor was usually induced in women with preterm premature rupture of membrane because of fear of sepsis. Two randomized trial in 90s compared induction of labor with expectant management. In both of these studies, neither induction of labor nor expectant management were proven to be superior for neonatal outcomes. Another study in 2017 compared planned early birth with expectant management for women with preterm premature rupture of membrane, and they found that there is no important difference in the incidence of neonatal sepsis in both groups. The another conclusion that a policy of expectant management with careful monitoring was associated with better outcomes for both the mother and the newborn. Finally, the American College of Obstetrician and Gynecologists has recommended that at 24 weeks of gestation up to 33 weeks plus 6 days, expectant management is recommended, while at 34 weeks of gestation or more, delivery is recommended. There are several considerations with expectant management. The first one is performance of digital cervical examination. In one study analyzed findings in women with preterm premature rupture of membrane expectantly managed between 24 and 32 weeks, they compared those who had one or more digital cervical examination with the women who were not examined. The outcome was those who were examined had 3 days rupture to delivery interval, compared with 5 days in those not examined. The second consideration is the use of tocolytics. Therapeutic tocolytics for those with ruptured membrane and labor has not provided significant perinatal benefit. On the other hand, in women with ruptured membrane and not in labor, prophylactic tocolytics doesn't improve neonatal outcomes but is associated with greater rates of chorioamnitis. There is uncertainty regarding preterm premature rupture of membrane in women who has undergone cervical cerclage. 114 women with cerclage in place who later had ruptured membrane before 34 weeks, they were compared with 288 controls. Pregnancy outcomes were the same in both groups, but circulatory retention for more than 24 hours after preterm premature rupture of membrane may be associated with prolonged pregnancy. However, there is increased risk of intrauterine infection. Other risk factors have been evaluated, such as active herpetic lesions who were managed expectantly. The infection morbidity appeared to be outweighed the risk of by the risk associated with preterm delivery. The other risk factor is expectant management of women with preterm premature rupture of membrane and non-cephalic presentation. was associated with higher rate of umbilical cord prolapse. As discussed earlier, infection is the major concern with membrane rupture. Some cases remain subclinical, but if chorioamnitis is diagnosed, the delivery should be prompt and preferably vaginally. The American College of Obstetricians and Gynecologists revised both the definition and the temperature for intrauterine infection, and the diagnosis of suspected intrauterine infection is made when the maternal temperature is equal to 39 degrees centigrade, or when the maternal temperature is 38 degrees centigrade plus one risk factor. These risk factors include low parity, multiple digital exam, the use of internal monitoring, meconium stain amniotic fluid, and certain genital tract pathogens like group B Streptococcus or sexually transmitted disease. Should antibiotic is given, reviewing 13 randomized trials performed before 35 weeks found that the use of antimicrobial therapy associated with significant reduction of chorioamnitis and neonatal sepsis, and also prolonged the pregnancy for 7 days. The antibiotic of choice is intravenous ampicillin plus erythromycin 6 hourly for 2 days, then oral amoxicillin and erythromycin 8 hourly for 5 days. Antimicrobial treated women had significant lower newborn with respiratory distress and necrotizing enterocolitis. Also, the latency period prolonged 50% of undelivered after 7 days. However, amoxicillin and clavulanic regimes was not recommended because it is associated with increased incidence of necrotizing enterocolitis. What is the role of corticosteroids? Corticosteroid administration accelerates fetal lung maturity. The American College of Obstetricians and Gynecologists recommends single dose of corticosteroids for pregnant women with premature rupture of membrane between 24 weeks and 34 weeks of gestation. I really hope you have enjoyed this lesson today, and if you have found it useful and you are not yet subscribed, then click the subscription button.